It's a pleasure to speak on cancer-associated thrombosis, mainly because people's eyes normally roll and they have that bored look in their face every time I mention it. So to actually have a captive audience with 71 people listening is absolutely lovely. So if I just try and share screen, and what I'm going to talk on is in many ways a follow-on from the talk I did yesterday. So those who didn't tune in yesterday, the talk I gave will be, it is available on the Thrombosis UK websites. And the talk was very much trying to highlight the fact that the guidelines that we've got are only as good as the data that informs them. And because the guidelines tend to be very purist in methodology, they tend to have just focus on the randomized control trials. So you need to really analyze and scrutinize the patients that were put into these studies, and in particular those who weren't, because it gives you an idea that actually the data doesn't refer to every patient. And in fact, what you find is that the patients who go into these studies are just like all pretty much all of an equalness. They're all similar, kind of average age of mid-60s, good performance status, low bleeding risk, relatively low thrombosis recurrence risk, etc. And about 50% of patients in the general population with cancer-associated thrombosis wouldn't even be able to get into these studies. So these data actually tell you the best outcomes that you're going to expect, which may not actually be what it's like in the real world. And I think that's the first thing. We need to know the limitations of the data. And here's Copernicus, who said to know, hang on a second, I'm just trying to minimize my picture so I can actually see what I'm reading here. So hang on, excuse me. Yeah, there we go. So to know that we know what we know, and to know that we do not know what we do not know is true knowledge. And actually, the most dangerous person is not someone who knows nothing. It's the person who knows nothing but doesn't realize it. It's fine to be ignorant so long as you're aware of your limitations. But in this situation, the person who doesn't understand the nuances of the DOACs or the interactions of some of these drugs, you know, if they're not aware of these things, if they're unknowingly ignorant, they are far more dangerous than the person who says, I know nothing, I'm going to refer to an expert. So when we look at what the evidence covers or doesn't cover, we see, you know, it does cover people with metastatic disease. In fact, there's a large proportion with Mets, not people with Mets in the brain because they didn't get into these studies. Patients with performance status of 0 to 2. So it tended to be the patients who were pretty healthy, really. Those who had a prognosis greater than 3 months. And as a palliative care physician, you know, a lot of the patients I see have got much poorer prognosis than that. Patients who have a platelet count above 75, weight above 40 kilograms, and no patients with active bleeding. And so once again, you know, all of these things, you know, it's reasonable not to put them into a study, but actually what you find is that this does encompass quite a large proportion of the patients we see in the real world. And it doesn't matter how good the guidelines are, you know, if they don't offer advice on what to do in these, it's no use to you when you're faced with this patient. You know, we don't have the luxury of choosing which patient we want to treat or not. And actually the data, I think, is limited with regards to central venous catheters and PICC lines, although we've had some good data on looking at warfarin and looking at low molecular weight heparin. None of the DOAC studies recruited patients with PICC lines or central venous catheters. The studies didn't recruit people with poor performance status. They didn't recruit people with primary or secondary brain. And I'm going to talk about those a little bit in a minute. Limited data on what to do beyond 6 months. We've always had this kind of fudge, which is, well, you should consider indefinite anticoagulation in patients with ongoing cancer, ongoing active cancer. The supposition being that that risk factor for thrombosis is still there. Fortunately, we are progressing now that there are studies being done Isabel Mayer's study, APICAT, is recruiting very well, and that is looking at what to do at 6 months anticoagulation, and whether or not apixaban should be given at the dose of 2.5 milligrams BD or 5 milligrams. And so I think that's a very important study for us to await the results of. And also clinical decision-making, because a lot of what we do is very nuanced and it takes into account patients' values and what is most important to them. And so, we have to treat the patient and what the patient feels is important rather than just the scan or the pathology. So, what we find is, there's lots of situations where the data really isn't there. So, for example, the very frail patient, extremes of body weight, or with renal impairment, the patient who is actively bleeding, how do we manage someone like that with a fresh clot, or someone with low platelets? And, none of the guidelines help there. And the best we can do is actually get consensus documents. And this document's almost, it's 9 years old now, but it still offers some sensible data based on expert opinion and experience, and extrapolates what research we currently do have. So I would commend that paper to you. And if we just have a look here at the exclusion criteria for these studies, the low molecular weight heparin ones and the DOAC ones, you'll see that patients with poor performance status, poor prognosis, and poor renal function in particular are not able to get into it. Now, I've seen data recently which suggests that about 50% of the elderly population will have a creatinine clearance of less than 30 mils per minute. So I think, in the elderly patients, the data is quite sparse. I'd remind you that the average age, the median age for patients in the DOAC studies was around 67. When I'm seeing in my population and some other population studies that have been published, the average median age of patients with cancer-associated thrombosis is mid to late 70s. So it's a large proportion of patients who wouldn't have been in these studies. The other thing is that when we look at the DOAC studies and we conclude that the DOACs are as good as, if not better than, the low molecular weight heparins, we've got to see that actually the populations in the DOAC studies tended to be patients with a better prognosis and performance status, and maybe less of a thrombotic burden as well. I mean, if we just have a look at clot, 40% of patients were dead after 6 months in the clot study. So only 60% were still alive. Whilst you look at these studies, at worst, 26% were dead after 6 months. Much larger figure, living longer, generally healthier. With the exception of Caravaggio, the proportion with metastatic disease was less. And those with performance status 2, clot study, over a third had performance status 2, and the rest were 1 and 0. That number's much lower again in these other studies. So what we're seeing is that the studies are kind of have been including in the DOACs patients which have better prognosis, living longer, less prothrombotic. So the guidelines are great for your healthy people, good prognosis, but how much they can apply to the more poorly population is questionable. And actually, I'm looking after palliative care patients, which we know have got a much higher proportion of patients with rethrombosis and bleeding. So where does this leave us? One population in particular people ask me questions about all the time are patients with brain tumors. And are we, should we anticoagulate them or not if you've got a primary brain tumor or you have brain metastases? Well, there's been a few systematic reviews and meta-analyses of the data. And I think this is a very helpful couple of forest plots. And what this is showing is bleeding rates in patients with, in the top, it's brain metastases in those who are anticoagulated or those who aren't. And in the bottom, it is those with glioblastomas. So just to interpret this for you, there didn't appear to be any difference in bleeding, intracranial bleeding in patients with brain metastases, regardless of whether you're anticoagulated or not. So the take-home message, you've got someone with brain mets, you don't know whether to anticoagulate or not. These data would suggest to you that anticoagulation does not increase the risk of intracerebral bleeding. And I've also seen there's a publication which suggests that even if you look at the more vascular of the brain tumors, there doesn't appear to be an increased risk in those either. Now, the only exception here is if you've got someone who's already had a bleed, because we know that a risk factor for a bleed is a previous bleed. So, you know, if you've got someone who's got hemorrhagic brain mets, I would not be starting them on an anticoagulant. But if there's these people who've got brain mets, no evidence of hemorrhage, yeah, I'd have no problem with starting them on an anticoagulant. Gliomas, glioblastomas are a different matter. Now, these are highly thrombotic. Some data that's been done by colleagues in Vienna would suggest its expression of a protein called podoplanin, which is certainly associated with, if not causative, of these clots. But glioblastomas are also highly hemorrhagic. And depending on which case series you look at, up to 25% of patients may have an intracerebral hemorrhage or intratumoral hemorrhage if anticoagulated. And this forest plot quite clearly suggests that your risk of intracerebral bleed is significantly increased if you anticoagulate. So I'm not saying don't anticoagulate, but I'm saying do so with extreme caution. And my practice would be to think very carefully about whether we need to anticoagulate or not. Could we rescan the patient and see if the clot is resorbing on his own volition? Or I may anticoagulate them initially and then drop the dose of anticoagulant down very quickly. But the take-home message there is just be very wary. So which anticoagulant should we use? And in the cancer situation, I am thinking of can we use DOACs? Should we use DOACs over low molecular weight heparin? So once again, there's not much data out there. And my advice would be your usual caveats apply. So our decision to anticoagulate with a DOAC is always dependent on what primary tumor it is, being cautious in patients with urothelial and GI cancers, ensuring there aren't any significant drug-drug interactions, and also ensuring that renal clearance is satisfactory and there is no bleeding evident. Now, there is a study which was published in one of the ASH open line blood advances. And this is a small number, but I think it is just kind of helps a little bit. And it's looking at patients with brain metastases who received either DOACs or low molecular weight heparin for thrombosis. And although they are small numbers, but what it does suggest is that the DOACs were associated with a lower rate of major intracerebral hemorrhage. If we were looking at any intracerebral hemorrhage, there wasn't too much of a difference considering the numbers. But I think in the very least, it suggests to us that DOACs are as good, maybe a little bit better on a safety perspective for patients with brain metastases. So don't feel that you can't use them. So now let's just talk about the palliative care patient or the patient with advanced cancer nearing the end of life. Now, we know that they are a real challenge in anticoagulation because they are highly thrombotic and have a high rate of recurrent thrombosis. They have a high risk of bleeding. They usually will have other comorbidities, waxing and waning hepatic and renal function. And also they tend not to absorb their drugs as well, and I'll explain that in a minute. Because they're on tons of different drugs, there's lots of drug-drug interaction potential. But the one thing is, as well, is that we need to be focusing far more on how the thrombus affects the patient rather than ultimate long-term survival. Now, I show this slide in a lot of palliative care talks I do, because it is very normal for our patients to become cachectic and hypoalbuminemic, often because of the fact they have a hypercatabolic state or their GI intake is low. But basically, when you drop your albumin, it's not just your ankles and your sacrum which becomes edematous. Also, your bowel will become edematous as well. And if you look on the left, you can see all these villi, which if you dip into your dim and distant past of physiology, you remember that the villi are there to increase the surface area and improve absorption of your foods and your drugs. And they always say that you've got the kind of surface area of a tennis court to absorb drugs and food across. If you have a low albumin and your villi become edematous, they all stick together and the surface area changes from a tennis court to just pi r squared times length. Much harder for some drugs to cross an edematous bowel. And I've often seen patients who are having no symptomatic benefit from oral medicines, but when they're given the same dose parenterally, the drug gets absorbed and works. So I think we have to be, cautious that DOACs may not always be absorbed as well in the advanced cancer patient. The other thing is, in the palliative care, the studies are really done differently. We're not represented in the major clinical trials. The data in palliative care is usually observational, and the clinical outcomes are far more looking at quality of life and symptom control rather than prolongation of survival. Also, these people are often on supportive care medicines, which may interact. I think we've got limited evidence in palliative care with the DOACs. I think we've been more cautious about using them. I think that's because we don't have as much data in extremes of body weight. And actually, we find ourselves with a lot of very cachectic people, and also some very large people as well, for those who've been on long-term steroids for their medicines. Our patients who are thrombocytopenic, especially when there's bone marrow involvement, we don't have as much experience in brain mets as we've said. All the strange sites where you may get thromboses, cerebral sinus thrombosis, portal vein thrombosis, etc. These people didn't get into the studies. And there's very little data as well in our patient population as to what to do when you're on full dose anticoagulation and you get recurrent thrombosis. And finally, how do we manage these patients when they bleed? And in palliative care, we see a lot of bleeding going on. So I think the first thing I'd say is treat the patient and not the scan. Decide what you're trying to achieve. So, I mean, I genuinely got a referral a few weeks ago. And this is where people did not engage brain. 91-year-old lady admitted with breathlessness. They did a CTPA, which showed us an isolated subsegmental PE. She also had a hemoglobin of 61. So they transfused her, anticoagulated her, and asked if I'd review her in the cancer-associated thrombosis clinic. Now, for those of you who haven't fallen off your chair, I'll explain the concerns I had there. First of all, I suspect a hemoglobin in the 60s is what was making this person breathless, and I think the isolated subsegmental PE had very little to do with it. Number two, no one was looking at what the cause of the low hemoglobin was, which I think was far more urgent. and I would be concerned they were bleeding. And so to help the bleeding, they anticoagulated them as well, because that really wasn't a sensible thing. So actually engage your brain and think about the patient. And if someone had actually first thought, this is a small clot, could it be what's causing the symptoms? And how much do we want to really anticoagulate? Maybe it'd be better if we had a look at the legs, see if there's any clot in the legs that could be causing a problem later on. I certainly would have been wary of anticoagulating that person for all the reasons I've said. So also, don't do a scan unless you're going to act on it. So, I thought sometimes it's better to just treat the symptoms for the patients. But likewise, avoid nihilism. Just because someone has got advanced disease, if they've got symptoms, anticoagulation is a good symptom control measure for VTE. So make an overall evaluation. And if this person has had a clot that's precipitated by systemic anti-cancer therapies, I think it would be reasonable. You're giving this person the benefit of the doubt and trying to modify the cancer. I think it's quite reasonable to treat the complication of the treatment you've given them. But if this is someone who's on only symptom control medicines and is just having symptom control measures, introducing a drug which has a modest risk of major bleeding may not be the best thing, may not be the best way to manage their symptoms. And I think that's the thing that we need to think about. It's a change in mindset, that we are not there to treat the clot. They say to every, to a hammer, everything is a nail, and it's true. It's sometimes you think to a hematologist or a thrombosis expert, every clot is there to be anticoagulated, when actually we sometimes need a far more broad, holistic approach. So which anticoagulant in the palliative care setting? Absolute no-no to warfarin. We've got a lot of data to say that it is people's anticoagulation is unstable. They require lots of INR medicine monitoring, drug-drug interactions, etc. Most of our experiences with low molecular weight heparin, and I think in the advanced cancer situation, we know the drug's being absorbed. We don't have so many drug-drug interactions. And I'd say, if in doubt, go with low molecular weight heparin. I think it is more predictable. We're able to adjust the dose. We can kind of run people slightly subtherapeutic if we need to. And patients do find it available in the context of their illness, but they may struggle long term. So yes, DOACs can be used, but just think carefully. And if in doubt, I still go with low molecular weight heparin. When to stop anticoagulation, because this is the one that I see people on them all the time when they've been on it for a year and a half for a small clot and they're covered in bruises or they've had bleeding problems. What I would say is, in the advanced cancer patient, have a low threshold for stopping. There was a study in French hospice which showed, and I'm just going to zoom through these because of time, but what it showed is that these patients tend to have a high risk of bleeding anyway. So just over 8% had bleeding complications, even if they weren't on anticoagulants, but 11% of patients in the hospice who are on anticoagulants or antiplatelet agents had clinically relevant bleeding. We also did an observational study looking at patients who went through our cancer-associated thrombosis service, at just over 200 patients who had been anticoagulated and subsequently died. A large spread of different cancers, predominantly colorectal, breast, but a large spread of others as well. And what we found is the majority of patients were actually anticoagulated until the point of death, or up to 7 days prior to death. And of those, 7% had a major hemorrhage. I believe that was significant enough for the notes to mention it. Now, if you're in the last week of life, usually we know that this person is now dying. We've been rationalizing the medicines. We've been stopping non-essential drugs. And I think it is quite reasonable that we'd be stopping anticoagulants, because any symptoms that they may get that could be attributable to recurrent clot, we could manage with end-of-life medicines. So I would say that someone who's approaching end of life, have a very low threshold for stopping anticoagulants. I'm going to leave it there. I'm happy to take any questions, but once again, thank you very much for the invitation to speak, and I will take questions if you want me to.
Thank you very much, Simon, for that really interesting talk. I always like listening to you, because you always put things over in such a clear manner, and it's just so easy to listen to you, and to, for all levels of understanding. So thank you very much for that. If you've got a question, please put it on the Q&A. There is one
question. Yeah, sorry.
Yeah, there is a question on there, but it's more related to.
There is a question for Simon.
Well, there is a question on there.
Yeah.
Actually, yeah, sorry, that's swapped with the one that was on there. Right, so, okay, so I've got an anonymous question here for Professor Noble regarding hypoalbuminemia, so hypo, and DOACs. Is there also an issue of protein binding, particularly with rivaroxaban? Does this factor into the decision process on DOACs?
The short answer is yes. And people don't tend to think about this, because once again, the patients who went into the DOAC studies were of good performance status, and you ain't getting into one of these studies with an albumin of 20. So I think you're absolutely right. Protein binding, and if you've got less albumin, you have less protein binding of drugs, and depending on the drugs, it may result in there being more free drug in the bloodstream. And this doesn't just kind of sit with DOACs, it sits with all sorts. Be very wary of some of the anticonvulsants. I've seen this where I've had patients who have become drowsy, and everyone thought they were dying, and actually they've just been dropping their albumin, and they've ended up with a much higher level of free and unbound anticonvulsants, which is making them sleepy, and you just drop that dose down. So in that situation, I would be wary again with using DOACs. I think it's going to be more predictable. Now, the other thing, of course, is that we don't routinely measure anti-10A levels, but we can do that in clinical practice to guide us. We are getting more experience of using DOAC levels, but these drugs were not invented with the intention of doing levels. And so we'll get a level and we won't actually know what it means. We tend to just look at it and say, well, yep, they're absorbing something, they've got some DOAC circulating, so that's probably all right. But yeah, it's a very good question, and absolutely agree. I'd be mindful in the context of low albumin. Also be mindful for some patients in the context of excellent renal function. We know that patients with a creatinine clearance of greater than 90, tend to metabolize edoxaban very well. And I have seen one or two patients who've had a resistant thrombosis, and it was more because they were clearing their edoxaban too well, rather than actually complete failure of the anticoagulant. They just didn't have enough in their system.
Okay, thank you very much for that, Simon. And thank you, Valerie, for your comment as well. The other question that was on there was a question regarding the collecting data off the radiology system and linking it with patients' hospital stay or discharge up to 90 days, so they could use that as a method of identifying patients who required a root cause analysis following the development of a VTE. Did you want to answer that, Marilyn? I saw that you were addressing it.
I answered it just to say we have a similar problem, really, that we can't engage our radiologists to put in place a passcode that would enable us to be able to pick up these cases. So we rely on a huge lexicon of figures that we've terms that we've developed over the years to try and capture a VTE in the many forms that it's documented in a report. But it would be a lot easier if we had a path code. And I know some health boards in Wales did get that into place, but not all of them.
No.
In Iron Bevan, we had a very good system, and it's still going. And radiologists have been very kind, and you will see scans will report at the end of the say positive for VTE. And although you may need to sift through to say, is this acute, is this resolving or something, it at least takes those that have clots and then allows a human to then interpret it, but the computer will pull those out and cross-reference with those who've had an admission within the last 90 days. And yes, you've still got to engage brain. You've got to look at those who, someone comes in with a DVT, they will get picked up as well. But, you can filter those out then.
Perhaps we need to revisit that again through the steering group. And because it wasn't a case that it couldn't be done. It was a case that some of the clinicians were reluctant to engage with it. So maybe that's one for a future meeting.
And I think, sorry, I was going to just go into I'm not going to rant here, but I'll just say that I think with regards to the changes that are going to happen within Wales, and because of the work of the Welsh Risk Pool, this has basically been brought upon ourselves. And also I think the decision not to return to Welsh government, I think is unfortunate, but I think it's the fact that we are, we aren't actually mandating completing the risk assessment tool as the NICE standards have said. And what's happening, for people to understand, is that the Welsh Risk Pool will assess a case and they'll decide whether or not they think it could be defended, or if it would be defended, how much it would take. Now, no one really wants to try in a court of law defending a hospital-acquired thrombosis case, because if, for the sake of argument, you pay out 40k, without going to court for a missed hospital-acquired thrombosis, or for someone who gets a clot who didn't have appropriate prevention, that's 40k. You pay that out. But if we go to court and someone gets a settlement there in their favour for, say, $250,000, that is then telling you what the going rate for a hospital-acquired thrombosis is. And you're opening the floodgates, and you've then got your tariff of how much it is worth. At the moment, every thrombosis-related case a Welsh Risk Pool settle, it's costing them about 170k each. And each health board will have been told how many of those the risk pool are spending. But they're spending about 10 million quid a year in paying for legal consequences of hospital-acquired thrombosis. So that's why they've taken notice of this. And they have assessed that with what we're currently doing, even though it's with the best of intentions, and even though our hat rates have gone down, those that are coming through aren't defendable. So each health board, they can go do their sums. I think, a health board that's only having 2 cases a year come through, that is still, you're coming up to, when you add in all the additional costs, you're coming into just under £500,000 quid a year. So I think when we're looking at, is that group going to be willing to do it or is it not? This is now in the hands of the exec and the medical directors as to how this is made to happen. And for us, what we have to be saying to them is, this is what we need. We need a specific thrombosis nurse, pharmacist, and a clinical lead who has dedicated time to do this and police this. And that is going to cost you much less than a good health board that's performing pretty well. It's going to cost you less than £500,000 a year, which the Welsh Risk Pool are not going to reimburse you for from now on.
Yeah, well, that's it. That's the bottom line. So hopefully this will prompt health boards to put trauma prophylaxis nurse in place in all of their hospital sites, and as Simon alluded to, a lead and a structure where all of this work is done as a matter of importance, and it gets the recognition that it should have, and the work will continue, and the HAT rate will hopefully continue to drop, the risk assessment will go up, and we'll achieve our goal. But we'll only do that if we get the engagement from our senior members of the health boards supporting us and encouraging clinical teams to do what needs to be done. So thank you for that, Simon. There was another question there. Does code embedding into radio?
No, I've started to answer that.
Oh, you've done it, have you?
Yeah, well, I'm starting to answer it. I think what they're alluding to is what Simon mentioned, that if you put B to E positive, then that's a diagnostic comment. And I think that's one of the arguments that radiology have in regards to the reporting. But if they used a path code, so a code that would not be visible on the actual report, then we could see it, or those of us who are going to be looking through the data would be able to see it and be more easily able to identify those cases, but the actual individual clinician who was reviewing the result wouldn't be able to see it.
Yeah, I think it's useful as well, because if you've got 500 cases on there that all need to be sifted through to see if it's got DVT, PE, VTE, whatever, compared with maybe 100 that have got the words on there, but maybe only 30 of them are need to be looked at, it's going to be a lot easier to go through 100 than 500 to pick out the ones that you do actually need to do a root cause analysis on. And even now, with the system in place, we all, I'm sure, get patients coming through that we don't need to do the root cause analysis on, and we can just put them aside and get on with the ones that do need doing. So even though it's still a bit of extra work, it's nowhere near as much work if they do nothing at all. So any more questions? If not, thank you very much, Simon. That was really interesting, as I said.